Ready now?
Can you scroll down because the first slide? Yes, now everything is good. Everything is good. Adrenal mass by Dr. Ahmed Al-Mutayri. Yes.
Bismillah ar-Rahman ar-Rahim. One thanks to all committee here to invite me in that nice event. Actually, this event has happened every year and really is added to me a lot of information in all aspects of internal medicine. Also, I want to thank Dr. Afaf for nice presentation, and as usual, Dr. Afaf is almost give good information and nice speakers. Actually, now just we'll touch some about the common endocrine referrals, and you can see that in any specialty, actually surgery, pediatric, or general practitioner, internal medicine. We'll found this adrenal incidentuloma. We'll touch how can approach this adrenal incidentuloma at level of general practitioner internal medicine, and we'll touch some little about the endocrinologist, how can approach that. Okay, this is one cases of 45 years old male, is not known any medical illnesses. He came to the emergency room with abdominal pain and requested by the emergency physician a CT scan abdomen to rule out acute appendicitis. Found this half right adrenal mass is about 2 centimeters. Actually, is referred to endocrine to approach assessment. Now, there is in adrenal mass, the two questions need to be answered. This is a real masses, is malignance or benign features. This masses is secreted or not. This is the two questions need to be answered about the adrenal masses. As in general approach to any medical referrals, this is need to take a detailed history. Really here, a detailed history to answer your questions. If any element in the history suggests of malignancy by family history or by have history of old malignancy, treated malignancy, can give a hint that maybe there's metastasis here to the adrenals. Are actually the history of any endocrine disease, any history of hypertension will help you to approach this adrenal masses or give suggestion this maybe have secreted hormone or not. Examination also will focus if any sign of over-secreted hormone, of any sign of other malignancy like hepatomegaly, splenomegaly, whatever. And then we'll go to the lab, how can lab requested, and what specific lab need to be requested for patient with adrenal incidentuloma, and to answer your question, dysfunction or not, and we'll go from there. Usually, the mass lesion greater than 1 centimeter, like this in our patient, accidentally finding, we'll call accidentuloma. And now that the accidentuloma prevalence is increased because the new modality of radiology and high resolution CT and small cut of CT scan or MRI, the prevalence is increased to found the adrenal incidentuloma. As I mentioned, we'll answer this is malignancy or functioning masses, and then we'll approach accordingly after the answer the two questions. There's over 700 cases autopsy showing the adrenal mass between 2 millimeter up to 4 centimeter. 90% of that patient or that is normotensive, 12% with hypertensive. About 61,000 of abdominal CT scan done almost in 9 years, or found 2,000 cases of adrenal masses, yani percentage around 3.4% as accidentuloma. In this case, 50% is metastatic, found to be metastasis, 25% is other known lesion, 7% symptomatic tumors, 16% is actually less than 1 centimeter. The high resolution scan, as I mentioned, is increased the prevalence of accidentuloma up to 5%. And we usually, when demonstrated by small cut or high resolution, we usually will see the shape of these masses either lateral or bilaterally. The most common is unilaterally and can be bilaterally masses. And the common, as I mentioned, is unilaterally. Unilaterally can be functioning or non-functioning. The function, the most common is adrenal adenoma, usually have over-secreted hormone. Adrenal carcinoma is very rare. Pheochromocytoma also is not common, or hyperplasia. Non-functioning, also adrenal adenoma can be non-functioning. Carcinoma also can be non-functioning, ganglionoma, myeloma, hemorrhage, or metastasis. Or metastasis. This is bilaterally masses. There is one study here as 800 to 2,000 cases with bilaterally. The most common is malignancy, metastasis, can be congenital adrenal hyperplasia, can be lymphoma, can be Cushing's, bilateral SGH dependent, can also amyloidosis, infections, chronic infection. Pheochromocytoma can appear as bilateral. This is repeated. The most common is can be SGH dependent Cushing, congenital adrenal hyperplasia, pheochromocytoma, Cohen syndrome, or hyperplastic. Non-functioning like metastasis or infections, or infiltrative like lymphoma or amyloidosis. This one CT scan shown on patient with HIV with non-Hodgkin lymphoma show bilaterally adrenal masses, bilateral large adrenal masses. The second one then with hepatocellular carcinoma with metastasis to the right adrenal and show that metastasis. This is one example about bilateral and unilateral. When I have one adrenal masses, can be non-functioning, but other contralateral can be functioning. For all patients with have bilateral adrenal masses should secrete screening for functioning hormone, because some one is unilateral non-functioning, but other can be functioning. That's, as I mentioned before, the cause of incidentinoma. The most common is adenoma, almost 94%. How can you evaluate now for malignancy? Usually malignancy really have characteristic masses. The first step to evaluate a malignancy about the characteristics of this masses in the CT scan. This will give an indicator or predictor with this, maybe this mass is malignant or abnormal masses, is not have benign features. And most commonly as maybe metastasis. Carcinoma, primary adrenal carcinoma is very rare, but other like metastasis is common rather than primary adrenal carcinoma. Can metastasis from lung cancers. As I mentioned, the size of that characteristic of imaging characteristic, good evaluated or predictor for masses and will give idea this malignancy, maybe malignancy or benign masses. Usually the diameter of that masses is a good predictor for malignancy. Usually the malignancy masses is large, and there is 90% above 4 centimeter associated with adrenal carcinoma. But large size is more with poor pregnancy prognosis. There is a national ITL study group show that 4 centimeter as a cut value with sensitivity 90%, specificity 60%. If more than 4 centimeter is highly sensitive for malignancy and high, a little bit specific for malignancy. In the CT scan, characteristic of masses will give idea about these masses. If the mass highly rich of lipid is benign masses. If lipid is less in these masses, go with abnormality or malignancy. In the CT scan, also have dense masses with house field. We'll speak about house field. It's very important predictor. The house field is a semi-quantitative method measuring X-ray attenuations. Typically, pre-contrast, when before the contrast go to the masses, if the adipose tissue would be high house field, the kidney high field. If the mass is with low house field in a non-enhanced CT scan, this meaning this mass is high density with fat. 100% is benign. Pre-contrast, if the house field is low, this mass is high fat density. Like this CT scan, you show non-contrast CT scan with a high attenuation. The house field is -2. It's very low house field. This is associated with benign adenoma. Actually here, 1.3 centimeter with high house field is not low, 4 centimeter, 40 house field with non-contrast CT scan high, suggestive of malignancy. After give the contrast, the predictor will wash out of this contrast after 10 minutes. If the contrast is wash out more than 50%, this associated with benign features. If less than 50% is associated with carcinoma or malignancy, with 100% specificity and sensitivity and specificity. Also, MRI can use assess the suggest evaluated of adrenal masses in the T1 if distinguish benign adenoma from malignancy by attenuations in the MRI. Also, gadolinium can use to differentiate the adenoma from malignancy. PET scan can use also to differentiate. The first standard is CT scan. This one picture about the PET scan and how show the attenuation of our high uptake of adrenal masses in metastasis patients with lymphoma. Now we'll focus about imaging characteristic for benign adrenal masses and abnormal adrenal masses or malignancy. In the benign, as I mentioned, we have small size, less than 4 centimeters, low house field, rapid contrast wash out, more than 50%. In the MRI is ISO intensity. This is more with benign adenoma. Pheochromocytoma usually as malignancy will have high vascularity masses, delay wash out of contrast, less than 50%. Also, house field will be high in 20, more than 20. In the MRI, high signal intensity in T2 may be associated with cystic and hemorrhagic, usually variable size. This is the characteristic of pheochromocytoma masses. Here also in the MRI will high intensity in T2. Adenocarcinoma, as I mentioned, irregular shape usually, which have necrosis more than 4 centimeters, high house field in non-enhanced CT scan, and delay wash out of contrast, less than 50%. This is highly suggestive for malignancy and maybe will appear of extra adrenal or metastasis or invasion. This local invasive or metastasis, this characteristic of adrenal carcinoma, as I mentioned, is rare. Metastasis usually irregular, smaller, usually bilaterally, as characteristic high house field with low washout. Other cyst or adrenal hemorrhage or myelolipoma. Actually, fine needle biopsy is not recommended to evaluate for adrenal mass, except or high suggestive malignancy to rule out pheochromocytoma. Need for staging for this malignancy, you can do FNA after rule-out pheochromocytoma. Now, now answer the malignancy by characteristic of the imaging. Now we'll answer dysfunction or not. As you know, the adrenal secreted three hormones, or cortisol, aldosterone, and 6 hormones. And medulla will secrete catecholamines. The 3 important hormones to be screening: the cortisol, hyperaldosteronism, and catecholamine to rule out pheochromocytoma. 6 to 20% of ascendentuloma have normal, abnormal, or over-secreted. Only 6 to 20%. 80% is unsecreted. 20% have hormonal secreted, hypersecreted. Usually, in hormone hypersecreted in large adrenal masses. In small adrenal mass, usually is not secreted. Sometime in the beginning of screening is not secreted, but with the follow-up within the first 3 years of adrenal masses will be after diagnosis will be conferred with secreted hormone. 85, as I mentioned, is non-functioning. 90% of functioning will secreted cortisol as subclinical Cushing syndrome. What's meaning subclinical? Usually patient does not have a clinical symptom and sign of Cushing syndrome. But if this patient even have secreted, over-secreted cortisol. If the most common secreted hormone in adrenal incidentuloma is cortisol. 4% will secreted catecholamine to cause pheochromocytoma. 2% will secreted aldosterone. After history and examination, well secreted, screening for pheochromocytoma, Cushing, and if patient have hypertensive, we're screening for hyperaldosteronism. This is as a summarize how can approach to the adrenal masses by history examination. If clinical suspicion by feature of masses in the CT or MRI, will go. If have suggestive Cushing syndrome, will screening for Cushing, serum cortisol or 24-hour cortisol. We'll mention this later on. Pheochromocytoma by plasma-free metanephrine or 24-hour catecholamine or metanephrine. If patient have hypertensive or hypokalemia, we'll screening for over-secreted aldosterone. Now, just will small speak about pheochromocytoma. As I mentioned, 3 to 10% of adrenal incidentuloma will found to have pheochromocytoma. You should screening all patients who have adrenal incidentuloma because pheochromocytoma is high risk for high rate for morbidity and mortality. 15% of cases have symptomatic when see patient. Screening by plasma-free metanephrine or 24-hour urine cortisol urine for metanephrine. Plasma highly sensitive and less specificity, but a good method for screening. Cushing, as I mentioned, is the most common secreted hormone in adrenal incidentuloma. As I mentioned, subclinical meaning the patient does not have a sign and symptom, but should be screening for. But before screening, should have roll out any interpret with your test by anything can decrease dexamethasone absorption or have drug can affect the test or have increased corticosteroid bound globulin like pregnancy or have in pseudo Cushing status should rule out before label the test. By Cushing, we'll do ACTH, then like low baseline ACTH, almost in 80% of the patient, lack of cortisol suppressed after 1 milligram dexamethasone overnight, 1 milligram dexamethasone suppression test up to 80%, subnormal 24-hour urine cortisol in also 75% of the patient. There is a change of circadian rhythm in the cortisol. You know, the cortisol in the morning is high, when the noon time is low, it will change the circadian rhythm of cortisol distribution is highly suggestive of Cushing syndrome. The screening by 1 milligram dexamethasone suppression test will give him 1 milligram dexamethasone overnight. Will test the cortisol in the morning, or by 24-hour urine cortisol collections, or some use salivary cortisol also. If the after dexamethasone suppression test is not suppressed and baseline SGH is low, some extended with used 2 days high dexamethasone indicate of confirmed extrahormonal secretion. This some guidelines suggestive of long dexamethasone suppression test, or 2 days high dexamethasone suppression test, or high dose dexamethasone suppression test by this. But for screening, 1 milligram dexamethasone suppression test is enough. Now we'll go primary hyperaldosteronism. We'll screen only if patient have hypertension or have hypokalemia. Hypokalemia is suggestive, but normal potassium is not exclude hyperaldosteronism. Screening by ratio of plasma aldosterone to plasma renin activity. How can manage of adrenal incidentuloma? If the cyst only aspirated and repeated CT scan after 1 year, that metastasis, carcinoma resected, or metastasis, if any, if need to be screening or staging, then after rollout of pheochromocytoma. If that acidentuloma less than 4 centimeter and benign feature in the CT scan and is no activity, just follow up. They're secreted, need to be adrenalectomy. It's more than 4 centimeters, highly suggestive of malignancy, adrenalectomy after hormonally evaluated. There is some entity of subclinical Cushing. Subclinical Cushing, if is not had good randomized trial, when will send the patient for adrenalectomy. But if have patient over secreted cortisol with more comorbidity and lack of suppression, and candidates for adrenalectomy. Summary. All patients should be evaluated for subclinical hormone hyperfunction and cancer. History and physical examination are very important initial assessment. Benign cortical adenoma, homogeneous, less than 4 centimeter, smooth, low attenuation or house field, rapid contrast washout. Imaging suggestive adenocarcinoma, as I mentioned, is a regular shape, high house field, less washout, more large size, more than 4 centimeters. Pheochromocytoma should be excluded by plasma or 24-hour metanephrine. Subclinical Cushing should be screening by 1 milligram overnight dexamethasone or 24-hour urine cortisol. Primary aldosteronism need to be screening for hypertensive patient by aldosterone to renin ratio. Surgery for a pheochromocytoma, hyperaldosteronism, subclinical Cushing if have disorder like diabetes, hypertension, and osteoporosis, are recommended to do the surgery, adrenalectomy. If have patient more large size, have evidence of metastasis, after exclude of pheochromocytoma, it's suggested to do the surgery or treated underlying cause like infections over the primary malignancy. Thank you. This is about adrenal incidentuloma.
Thank you, Dr. Ahmed. Currently, we don't have any question. Okay, thank you for this nice presentation, Dr. Ahmed. And now you may stay with us and attend with us the presentation presented by Dr. Hussein Raif. Dr. Hussein Waif is a consultant endocrinologist in Dalla Hospital, and today he will talk about hypercalcemia for practitioner. Thank you, Dr. Hussein.
Hi, assalamu alaikum.
Walaikum assalam wa rahmatullah.
Just as a correction, I'm
sorry for this.
Riyadh. I didn't have the
Dr. Hussein, we cannot hear you. Dr. Hussein, you are mute. If you can hear me, please stop sharing your screen and start sharing again. Dr. Hussein Waif, consultant endocrinology in King Faisal Specialized Hospital, and we are happy to have him with us today.
are you able to see the screen or not yet?
Yes, sure.
No.
It comes and then disappeared. Also, your video is the same. I think we have a connection problem.
Connection ضعيف.
Dr. Hussein, can you hear us? نتكلم في التليفون أحسن.
Yeah, I'm trying to share my screen. Do you have it now? I had to leave and share the screen one more time, just a second. Yeah. Do you see the screen now or not yet? Do you see the screen or not yet?
Not yet, doctor. Not yet.
No?
No.
I don't know
Yes,
why.
yes. Now okay.
You
now
do?
okay.
Okay, great.
Okay. So again, because of the connection problem, we have Dr. Hussein Waif from King Faisal Specialized Hospital and Research Center. Dr. Hussein is a consultant endocrinologist, and now we will present hypercalcemia for the practitioner. Thank you, Dr. Hussein, for joining us.
Thank you. Thank you. Do you see this slide now, or?
Yes, I see the first slide.
Okay, because, okay, all right, great.
Okay, you may make a full screen, yes, like this. Okay.
Okay, thank you.
Okay.
I don't know why there was some distortion of the slide. Anyway, thank you so much, and sorry for not being on time for the schedule, the original schedule, because of urgent medical issues. I enjoyed the last part of my colleague talking about pheochromocytoma. My talk today will be a common thing, maybe not as rare as pheochromocytoma, but certainly, of course, adrenal nodules are not so rare. This is probably a more common issue that we see in the hospital, especially for practitioners in the hospital, but also in the outpatient clinic, which is hypercalcemia. This is a study that was done to show what are the commonly causes of hypercalcemia when they present in the emergency room. And I have to say that the emergency room, of course, does not represent the real or the average causes of hypercalcemia, because hypercalcemia in the hospital or in the emergency room have a little bit different etiology than when you face it in your clinic. So causes of hypercalcemia in the emergency room, according to this study, was 35% of the time due to malignancy. And 2/3 of those malignancies were solid tumors, and 1/3 was hematological malignancies. And about 25% were primary hyperparathyroidism. So clearly those two items are the most common items or common causes of hypercalcemia, where of course primary hyperpara is more common in the outpatient setting. And then as you see here in the emergency room, at least 30%, 1/3 of the cases of hypercalcemia were of unknown etiology. And you can see the rest distribute between immobilization or rare causes like sarcoidosis or drug-induced. Again, the reason those patients presented to the emergency room is weakness in about half of the cases, GI symptoms of nausea in 28% of the cases, or some sort of neurological or psychological symptom of sleepiness or disorientation in about, again, 20% of the cases. So as you know, the regulation of calcium is extremely tight. Calcium is bound to albumin. About in 45% of the calcium we measure is bound to albumin, and another 45% is free, or what we call ionized, and then there's a small portion that's connected to phosphate or citrate. We also know that we need to correct the calcium to the albumin level, and in general, for each 10 gram per liter decrease in albumin, let's say a 30 gram per liter instead of average of 40, we need to cut down or correct the calcium level by 0.2 for each 10 gram or 0.02 for each 1 gram decrease in albumin. So in a normal day, we consume about 1 gram of calcium. About 200 milligrams of this calcium get absorbed, and exactly 200 milligrams get excreted. So the same amount we absorb is excreted, and then there is, of course, a zero balance. This is in spite of so much of the calcium getting filtrated through the kidney, but this tells you the ability of our homeostasis and hormones and other mechanisms to reabsorb calcium and keep it in check. Those players, if you want, for physiologic players or regulator of calcium homeostasis are mostly the PTH, the vitamin D, the calcium receptors and the parathyroid gland and kidney, and the vitamin D receptors, which exist everywhere in the body. We will talk a little bit about this so we understand the physiology, because if we understand it correctly, it's easier to understand hypercalcemia and the etiology of hypercalcemia. There is a very tight and good relationship between PTH here on the y-axis and calcium here on the x-axis. So a normal PTH with a normal calcium is what we expect in a normal person. However, if the calcium goes down, goes lower, so as you see here, 7 or 8 milligrams per deciliter, we expect the PTH to go up. This is normal physiology. So if the PTH was low, in spite of low calcium, this is a condition of hypoparathyroidism. If the calcium is high, so there's a hypercalcemia, we expect the PTH to go down. And this is a normal response. And this is what we see actually in hypercalcemia of malignancy, that the PTH respond down because the cause of calcium of hypercalcemia in this situation is not a PTH related. However, in primary hyperpara, we see both calcium and PTH to be elevated. So calcium receptors are another player, or one player that exists on the parathyroid gland. This is a parathyroid cell. And when the calcium increase, if there is any increase in serum calcium, the calcium receptor will be stimulated, and this will lead to a negative feedback, suppressing the PTH secretion and synthesis. Those same receptors also exist in the kidney, and if the calcium level in the blood and the one filtrate in the kidney is increased, then this receptor will inhibit calcium reabsorption from the kidney, and this is why we get hypercalciuria when the serum calcium is elevated. The other important player is PTH, and PTH work on PTH receptor. We will look in the function of the PTH in the next slide. But now I want to tell you that the PTH receptor also can respond to PTH-related peptide. This is an important hormone that is secreted in the body and secreted by certain malignancies. So PTH-related peptide is a larger protein, larger than PTH, but both of them work exactly on the same receptor, which is the PTH receptor. So this is why when we have PTH-related peptide increased in certain malignancies, we're going to get the result very, very similar to an increase in PTH, which is high calcium and low phosphate. And the only way to differentiate is to measure the PTH, as the PTH will be low in this situation. So this is the physiology of PTH function as depicted in this diagram. So parathyroid works mostly on the kidney, the bone, and indirectly on the gut. PTH, or parathyroid hormone, that comes from the parathyroid glands, will work on the kidney by doing two things: stimulating the conversion of 125 hydroxy vitamin D to 125 hydroxy, which is the active 125 dihydroxy vitamin D, by stimulating the enzyme, which is the 1-alpha hydroxylase. So this is how PTH increase the active vitamin D. The other function is on the kidney, on the tubules, which is increasing absorption of calcium and increased excretion of the phosphate. It also works on the bone, and PTH on the bone will increase bone resorption, therefore increasing calcium and phosphate resorption from the bone to the blood. Because it increased 125 hydroxy vitamin D, the 125 hydroxy vitamin D will work on the calcium absorption in the gut. So PTH does not work directly on the gut, but works on the kidney and the bone. And the 125 hydroxy vitamin D works on the gut. So again, on the kidney, the PTH work on the proximal tubules, and this is where most of the excretion of the phosphate occurs. It works also on the distal tubules and the collecting tubules in the kidney, and this is where most of the calcium reabsorption would occur under effect of the PTH. All right, now going to the thrust of this talk would be the causes of hypercalcemia. So understanding this physiology will help us. Let's go through the different types of hypercalcemia that we can face. And this is one classification. There are so many classifications for hypercalcemia to help understand the pathophysiology and also to help understand or help the diagnosis of the cause of this hypercalcemia. So there are endocrine causes. And the endocrine disorders or causes, which are the most important, as well as the malignant associated hypercalcemia, so those two items, the endocrine disorders can be divided in those that is PTH related, so there's an excess PTH production, or those without excess PTH production. And the malignancy associated hypercalcemia, MAH, can also be divided in those related to the PTH related peptide. This is the large protein that works exactly like PTH, but not measured as with the PTH assay, of course, or with another mechanisms that is not related to PTH related peptide. And we will talk about this in more details. And then there are other causes like inflammatory disorders, like granulomatous disorders of the lung, TB or sarcoidosis, AIDS, HIV infection, AIDS can also be associated with hypercalcemia. There are some rare pediatric syndrome that we will not discuss today. And then there are medication-induced hypercalcemia. And the most common one are the thiazide related, because this is important because PTH can be slightly elevated in this one, as well as the lithium, but it will be suppressed in every other cause other than thiazide and lithium. So vitamin A or D and certain other medication, and also the milk alkali syndrome will also can cause hypercalcemia with a low PTH. And then we have the immobilization, which is something we can see almost always in the inpatient setting. So let's go with the probably the most important one are those endocrine disorders associated with hypercalcemia, and the one that has either excess PTH or without excess PTH. So again, we went through this, which is the effect of PTH on the bone, on the kidney. So I'm not gonna stop here. And the symptoms of excess production of parathyroid hormone, or what we call primary hyperparathyroidism, is related mostly to an increase in calcium, but there are some symptoms maybe related to the PTH itself. And traditionally, those syndromes of primary hyperparathyroidism were associated with classical symptoms that we don't see so much lately, which is the symptoms of polyuria, polydipsia, renal stone or nephrocalcinosis, or bone symptoms like aches and pain, and in severe cases, of course, the osteomalacia or the osteitis fibrosa cystica. Psychological, neurological symptoms like lethargy and depression, GI symptoms like constipation and peptic ulcer disease. Nowadays, of course, we don't see this picture. And most of the time, 80% of the cases of primary hyperparathyroidism now actually present as either very mild or asymptomatic disease that discovered because of lab tests. However, we still see a fair amount of renal issues like renal stone due to hypercalciuria. So still, even in the, I call the modern form of primary hyperparathyroidism, 35 to 40% of the patient will have some sort of either kidney stones or hypercalciuria in spite of being fairly asymptomatic. I just want to alert you that there are some genetic causes for primary hyperparathyroidism. We see it in men 1 and less in men 2, the multiple endocrine neoplasia type 1 and type 2, and in rare syndrome called the hyperparathyroidism Joe syndrome, or this is a genetic disease that wears multiple usually parathyroid adenomas associated with a real tumor in the jaw, and sometimes it might turn to parathyroid cancer. So how do we diagnose primary hyperparathyroidism? Of course, the chemical diagnosis is very easy because hypercalcemia, hypophosphatemia with a high PTH in a normal renal function, or not, at least no advanced renal impairment, is almost always indicate primary hyperparathyroidism. And then, of course, ultrasound or parathyroid scan can detect the parathyroid adenoma, although not always. Sometimes we may not have a positive radiology test. What are the indications to treat patients with primary hyperparathyroidism? Any patient with primary hyperparathyroidism who have symptoms should probably consider for surgery. But what about those asymptomatic? We said almost 70 to 80% nowadays are asymptomatic. So if the serum calcium is more than 0.25 millimole or 1 milligram above the upper normal limit, if they have excessive hypercalciuria more than 10 millimole per day, or decreased creatinine clearance, clear osteoporosis, or age less than 50 years, that would be an indication to surgical treatment. Differential diagnosis should always include, of course, a condition called familial benign hypercalcemia. This is a problem with the calcium sensing receptor. And because of this, there's an increase in calcium level and PTH level, but those patients have completely normal, no symptoms and no complications. And if you measure their urine calcium, the urine calcium is extremely low. And this is how we differentiate, plus the presence of a family history. And those patients should not be operated on at all. Of course, we always have to rule out tertiary hyperpara, which we see in advanced CKD. And here, of course, the phosphate will be high, not low. And occasionally, a condition called hypophosphatemic rickets can lead eventually to tertiary hyperpara. Also, after renal transplant in CKD patients, sometimes we see hyperparathyroidism that might require surgery. Now, if we move to the PTH-independent endocrine related hypercalcemia, there are conditions like hyperthyroidism, pheochromocytoma, vipoma, or even adrenal insufficiency that can be associated with mild elevation of calcium level, not related actually to PTH. So PTH in this case will be low. At least in hyperthyroidism, it's a direct effect of the thyroxine on the bone. Now, the other very important cause of hypercalcemia, and as we said, the most important one in the inpatient setting and the emergency room setting, will be malignancy associated. And out of this, the most common is the one related to this protein called PTH-related protein. Actually, believe it or not, 10% of malignancies can lead to hypercalcemia. So it's pretty common. And in about 50 to 90% of the cases related to PTH-related peptide, so the picture might look exactly like primary hyperparathyroidism with high calcium, low phosphate, but the PTH will be low. And if you measure PTH-related peptide, it will be high, but most of us will not measure, and it will be sufficient to show suppressed PTH to make the diagnosis. And usually those malignancies are obvious. They're not hidden. You can find them with your clinical history. So the most common one is the PTH-related peptide, and this is what we see with solid tumors and occasionally with hematological tumors. However, there are other ways of humoral-mediated hypercalcemia or malignancy-related hypercalcemia, which may be related to overproduction of 1,25-dihydroxyvitamin D, or very, very rarely ectopic even PTH production, which was reported rarely in some cancers. So what is sorry. Okay.
Assalamu alaikum.
I'm losing my slides here. Okay.
Okay.
All right. So
okay, it is appearing now. It is appearing, no problem.
okay, thank you so much. I'm sorry again. I don't know what's happening. So if we talk just a little about PTH-related peptide, this is, of course, a peptide that can be secreted directly by the tumor. It doesn't have to, you don't have to have the bone metastasis. Although sometimes even with bone metastasis, this PTH-related peptide can be produced at the bone level or at the tumor level, and therefore can cause this hypercalcemia. As we said, it works primarily the same way as PTH works. I have my slides frozen now. Let's see. I don't know whether I should stop sharing and go back again.
I think you stop sharing and reshare again. Yes.
Okay.
Only a few slides left, right?
Yes, that's true.
Okay.
All right. Okay, I don't know. I have some issues with the connection. So, okay, here we are. So, okay. So we talked about the PTH related, but as we said, there are other causes of malignancy that can cause hypercalcemia. Example, lymphoma, especially humoral related, due to excess production of 1,25-hydroxyvitamin D. But this can be seen even in non-malignancy like any granulomatous disease, sarcoidosis, even the HIV, the AIDS, is actually mediated through the excess production of 1,25-dihydroxyvitamin D. Immobilization is a relatively common cause of hypercalcemia in the hospital setting, and this is usually seen in when there is a very much decreased mechanical load to the bone due to very prolonged hospitalization, seen usually after burns or spinal injury. And finally, we should not forget medication-induced. And as I mentioned before, in thiazide and lithium-induced, PTH may be slightly related, so it can be confusing. But the rest of those, especially the milk alkali, the vitamin D, of course, it will be low PTH. Now, we have mentioned a little bit the manifestation of hypercalcemia before, GI symptoms, renal symptoms of polyuria, polydipsia, neuromuscular symptoms of depression, confusion, and occasionally bradycardia and first-degree AV block and AV block. Now, just the pillars of treatment depends on hydration, inhibition of bone resorption, using calciuresis or excretion of calcium through the kidney, glucocorticoids indicated in certain situations like granulomatous disease, dialysis if there's a renal failure or certain very severe hypercalcemia, and then in some situations, calcimimetics like cinacalcet can be part of the treatment, and of course mobilization in case of immobilization. So the most important in emergency hypercalcemia, when the calcium is extremely high and the patient is symptomatic, is to replace fluid, and replacing fluid will help restoring the volume, and also will help increasing the calcium excretion, because calcium follows the sodium excretion in the kidney. Inhibition of more resorption is the second issue, and we usually use zoledronic acid at 4 or 5 milligram. We use sometimes calcitonin initially, but calcitonin works only for a few days. Zoledronic acid or pamidronate, bisphosphonate intravenously, will peak in 2 to 3 days. So you don't expect an immediate action, but about 48 to 72 hours. But you shouldn't give any of this before hydration. So usually 1 to 2 days of hydration, and then you can use zoledronic or bisphosphonate. However, calcitonin can be used immediately in severe hypercalcemia. We use sometimes diuretic, but I have to warn that furosemide is a good, of course, drug to force calcium out, but shouldn't be used before full hydration of the patient. Glucocorticoids only in cases that can respond, which is that one that are related to the increase of 1,25-hydroxyvitamin D, and in hematological malignancies and vitamin D intoxication or granulomatous disease. It does not work when it's a PTH-related peptide, which is the most common cause of hypercalcemia of malignancy, or regular PTH. Dialysis is usually reserved for the severe cases and in case of renal impairment. Cinacalcet or calcium mimetic can be used in certain situations, but they are not for emergency. They're used in more cold cases, and usually they work well in the tertiary hyperparathyroidism and in the rare cases of parathyroid carcinoma. Thank you so much, and sorry for the interruptions due to these logistic issues. Thank you.
Thank you, Dr. Hussein. It was a very nice presentation about hypercalcemia. And let me check for the questions.
One for me.
We don't have. I have one question about familial calciuric hypercalcemia. Do you use 24-hour collection for urine for calcium or calcium creatinine ratio in urine? Which is more precise?
Right. 24-hour urine calcium can be used, but the ratio is important. So I'm glad somebody mentioned this. The ratio is usually quite low, below 1. And that might indicate, of course, it's more accurate because you're also figuring the creatinine, level and the excretion. You're more accurate in calculating the excretion rate for calcium this way.
Okay, I mean, usually we ask the patient to make the calcium creatinine ratio. Okay, but for the sampling, do you like to make morning sample or evening sample, or to make 24 urine collection, then centrifuge and take a sample from it?
Right. So the 24-hour urine calcium, it is more accurate if you're going to calculate this, because it really represents the whole thing. But it is a little more difficult, and so some would use 2 hours urine collection, 2 hours instead of 24 hours.
2 hours.
Yeah, 2 hours urine collection, it might be enough.
I am asking this because, as you know, I am a nephrologist, and for measuring proteins in urine, sometimes we do 24 urine collection versus albumin creatinine ratio in urine. And to be precise, sometimes there is the urinal variation, and also it may be affected by the effort and activity of the patient. You know, there is something called the marathon proteinuria. If I will go jogging, sometimes I may suffer from transient proteinuria. That's why we like to make the patient resting and take the 24-hour urine, then take the sample. That's why I'm asking, is it the same in urinary calcium or not?
And certainly there's a difference also in excretion of calcium, depends on the food content of calcium, because when you are absorbing more calcium, you're going to excrete more calcium in the same time. So yeah, 24 hours certainly will be more accurate, especially if you're going to make a big decision out of it. but sometimes we use shorter duration, and we use, of course, the ratio to kind of correct for the less of a duration or more convenient for the patient. The benign familial hypercalcemia, or what we used to call hypercalcemic hypocalciuria, is a genetic disorder. So now actually we can do the genetic analysis of the calcium receptor to make an accurate or final diagnosis. But usually those patients have no symptoms and there's no indication to treat them, and there's a family history, and they had mild hypercalcemia on and off for long, long time without no symptoms or complications. So that would be the clue. And then the urine calcium is going to be extremely low, usually less than 1 millimole per day. So it is, yeah.
Yes. Okay, I understand. We have one question here regarding the management of hypercalcemia. Can we use calcitonin immediately?
Yes. So as I said, calcitonin, we don't use bisphosphonate right away because of the renal function and dehydration. And occasionally IV bisphosphonate can precipitate in the kidney as crystals and cause some renal damage if it's done within when the patient's dehydrated. So calcitonin, and I'm talking about, of course, severe hypercalcemia with symptoms. You can start calcitonin at a dose usually like 200 units twice daily, or maybe a higher dose even. And this will give you a good result within the next 48, 72 hours till you catch up on the hydration. And then you decide whether there's an indication to use steroids or to use bisphosphonate, depends on the cause of the hypercalcemia.
So, sometimes we use Lasix also.
So as I mentioned, furosemide can be used, but you have to be cautious. If you use it initially without hydrating the patient, you can make the hypercalcemia worse.
Sure.
So don't use it initially. I would use it later on after adequate hydration.
Okay. Thank you. Thank you, Dr.
You're welcome. You're welcome. Thank you so much.
And now we will go back to Dr. Ahmed Al-Mutawi. Thanks, Dr. Ahmed, for staying with us. Our presentation now, the second presentation, will be approach to thyroid nodule. Dr. Ahmed Al-Mutawi, consultant endocrinologist and assistant professor of internal medicine and endocrinology. Kindly start sharing your screen.
Dr. Ahmed, the screen is appear to all still?
Yes, I can see the screen, but it is not yet full screen. I can see the slide roll on the left side and the main slide.
Okay. Okay, now I think is appear now.
No, I think it is the same like last time. I think it's better to
stop again.
Stop sharing, then we share again, Manish. Yes, perfect.
Okay. I can start now, Dr. Ahmed?
Yes, please. Thank you.
Okay. Bismillah. Thanks again, Dr. Ahmed, to now, and also want to thank Dr. Hussein Raif for nice presentation about hypercalcemia as a common problem we'll see every day, and consultation every day for endocrine. Now, just also we'll speak again about this some common endocrine or common approach or common disease can be seen in any specialty, and even a common referral to endocrinology about the thyroid nodules. I don't know, the slide now is half. I think the slide is not moving all. Maybe the same problem with Dr. Hussein before. Dr. Ahmed, let me stop share and you hear me, Dr. Ahmed? Let me, I don't know that the slide is not moving.
We are with you, Dr. Ahmed. Any problem?
I think the slide is not moving. Maybe we'll stop sharing.
Stuck? Yes, yes. We start again. You may work without making a full screen. It's okay.
We'll see. Not. Now it's moving, Doctor. The screen
Yes,
is
yes. Now it's moving. If you want to try full screen, it's okay for me. Let's
see. Let's
let's
see.
see.
Okay. I think is now is okay. Bismillah.
Okay, okay, start.
Thanks. Okay. Okay. As I mentioned, the thyroid nodule is a common problem faces every time and refer to endocrine every time, and can all practitioners, general family medicine can found that problem. What thyroid nodule? Thyroid nodule, as you know, this discrete lesion within the thyroid gland and have surrounded by thyroid parenchyma, maybe palpable or not palpable. 22, almost 80% of population have clinically inappropriate and inapparent thyroid nodules. 7% were palpable, most of non-palpable. Will be highly incidence in elderly, in women, in iodine deficiency country, and have high risk or history of radiation exposures. Ultrasound is good modality to detect the thyroid nodule, is detected up to 70% of thyroid nodules. Non-palpable nodules have same risk of malignancy as palpable nodules. When have large nodule, will go with the risk for malignancy. Only the nodule more than 1 centimeter should be evaluated. Less than 1 centimeter is no need to be evaluated. This is what the percentage of cancer worldwide. The thyroid is almost 3% of cancer worldwide. Now, what causes thyroid nodules can be benign, can be malignancy, and can be not from the thyroid at all, is from outside the thyroid, and can be metastatic to the thyroid. Benign, the most common is adenoma, cyst, can be associated with thyroiditis or infection or infective disease to the thyroid or thyroid duct or teratoma. Malignancy, there is three types of malignancy: is papillary cancer or follicular cancer or medullary cancer, and can be anaplastic cancer or lymphoma. Non-thyroid, like a parathyroid cyst or adenoma, thymoma, lipoma, or cystic hyaroma, or bronchial cleft cyst, or paraganglioma or salivary tumor. Metastasis from kidney or breast or colon. The prevalence of cancer is higher in several groups, in the very young and very elderly. Both extremity of age is high risk for malignancy. When patients have history of head and neck radiation, high risk, or have family history of thyroid cancer, is high risk for malignancy. How can you evaluate it? As a general medical, this should be evaluated by history. We'll focus on history about any family history of thyroid cancer because this will give idea and will change our approach. And if I have history of any head and neck radiation, or have any what the rate of neck masses growth is, rapid growth when you have noticed, if any obstructive symptom associated with the thyroid nodule like dysphagia or dyspnea, any symptom of sign of hyper or hyperthyroid if have secreted or under-secreted. But the most of the thyroid nodule is asymptomatic. Physical exam, if the nodule is palpable or not palpable, will what the location is, consistency, the size of nodule is mobile or not mobile, tender or not tender, any cervical lymphadenopathy associated, and skin over is normal or not normal. After that, we'll go to the chemical evaluation. The first test to request is TSH. If TSH is normal or elevated, we'll go to the ultrasound. All patients need to be ultrasound. If palpable or not palpable, need to be do ultrasound. But if patient who have TSH is low, is high risk or suppressed, maybe need to investigate for free T4 or free T3 to evaluate thyroid status. If he's hyperthyroid, maybe we'll go as after ultrasound for thyroid uptake scan to evaluate the nodule about hot, cold, or cold according to the thyroid nodules. Thyroglobulin at the level evaluation of the nodule, not recommended to request it, but after treated or follow-up of thyroid cancer, yes. Calcitonin also is not the first, in the first evaluation, no need to request it except the family history of suspected medullary thyroid cancer by family history, or you think of medullary thyroid cancers if men too, you recommended for requested calcitonin. If all, as I mentioned, all patients should have thyroid ultrasound, even palpable or not palpable thyroid nodule, because according to the thyroid ultrasound feature will calcify the thyroid nodule to highly suspicious, low suspicious, or very low suspicious. And according to the size and characteristic of this nodule, will go approach this nodule by FNA or not, need to be do either step more evaluated or not. The ultrasound feature associated with the increased risk of thyroid cancer if this nodule.
I'm sorry for interruption, Dr. Ahmed, but the screen is still on hold. Can we stop sharing and reshare again?
Okay.
Sorry for this.
Now is okay, Dr. Ahmed?
Please scroll down till we reach the slide to see it is scrolling or not.
Okay. Let's try a full screening.
Okay.
I think as full screen is not work. You stop in watching ultrasound or
yes,
this is
yes,
slide?
yes. Yes, I see a thyroid ultrasound.
This is the last slide.
I think so. Yes, I think so. Yes.
Okay.
No. Yani restart from the slide you stopped in.
I think stopping this thyroid ultrasound.
Okay, we can proceed.
Okay. As I mentioned now, I'm sorry for that. Thyroid ultrasound, as I mentioned, all thyroid nodule should have ultrasound. Because the characteristic of the thyroid nodule in the ultrasound will calcify the thyroid nodule to high risk, low risk, high suspicious, or low suspicious malignancy. And according to that, we'll go to approach this nodule. Ultrasound feature associated with thyroid cancer of this nodule is hypoechoic or have solid hypoechoic with microcalcifications, have central vascularity, irregular margin, incomplete hollow of the nodules. If nodule is taller than a Y, this feature is highly suggestive for thyroid cancer. If the other feature is highly low-risk thyroid cancer, like hyperechoic, large nodule, peripheral vascularity, spongiform appearance, or have cystic appearance. This slide shows the ultrasound with calcified according to the ultrasound. The very highly suspicious of malignancy, up to 70 to 90% of malignancy, have solid hypoecho with microcalcifications, with irregular borders, have taller than the wide, as with cyst, and that with an abnormal lymph node. Intermediate suspicious of only hypoechoic and solid nodules. Low suspicious of have hyperechoic or azeochoic. Very low spongiform, very benign is purely cyst. This is, as I mentioned, when have highly suspicious, 90% have risk for malignancy if a need of more than 1 centimeter. Intermediate suspicious, need of more than 1 centimeter. Low suspicious of more than 1.5 centimeter. Very low suspicious if more than 2 centimeter. Benign, no need to have a biopsy. This is what called red calcified. This is ultrasound calcified. Have some point here after that collected the point that try 1 and try 2 that to the legs of malignancy. This is usually the same as high suspicious or low suspicious. How can management, according to the calcified in the ultrasound appearance, if the less than 1 centimeter, no FNA, just follow up, except if have risk for malignancy, high suspicion malignancy. Why? Strong family history of thyroid cancers. There's patient known syndrome of thyroid cancers, young age, preference FNA, or observations. This is depend on judgment of the physician according to the patient. But usually then less than 1 centimeter recommended just follow up. If after 6 to 12 months by ultrasound, if this is only less than 1 centimeter, if 1 year or 2 years, if have nodule with low intermediate suspicious in ultrasound, 2 to 3 years for low risk nodules. If the repeated ultrasound, the nodules increase by 20%, or have another feature like microcalcification or that, you recommended to do FNA. After that, we'll go to the FNA by ultrasound guided. After I think after FNA will calcify by Bethesda system. If 1 is non-diagnostic, 2 is benign, 3 is follicular lesion, 4 is follicular neoplasm, 5 suspicious malignancy, 6 is malignancy. Bethesda 1 is non-diagnostic. If do FNA but appears non-diagnostic, they will the judgment the recommended to repeated FNA approximately 4 to 6 weeks by ultrasound guided if done the previous FNA is not ultrasound guided. This is the slide appearance. Bethesda 2 with have benign nodule usually will just follow up with ultrasound as I mentioned. If the increase the nodule size, will repeat it FNA if more than if increase the size by 10% to 20% of diameter. This is appearance of Bethesda 2. Also, if have benign nodule, if have cystic appearance need to be aspirated. This is I mentioned when have increase in of the nodule diameter by 20% to repeated FNA. Bethesda 3 and 4 and have cystic show a follicular lesion or a TBF and it remains significant, or follicular neoplasm, this need to be a good approach. If this patient highly suspected, need to be repeated FNA to be 6 to 12 weeks. If the repeated one is still in the same category and the patient in high risk, we're recommended to do surgery by lipectomy or surgical biopsy by thyroid lipectomy. By surgical typical thyroid lipectomy to be evaluated. If the thyroid lipectomy show is typical malignancy like papillary, maybe need to be resurgery again to take it total thyroidectomy. But step 4, follicular neoplasm, you need to do the surgery by diagnostic lipectomy or total thyroidectomy, depending on the evaluated of the patient. But step 5, suspicious of malignancy, yes, if not definitive by biliary thyroid cancer, but patient high risk for malignancy, if the appearance is not suggestive of papillary thyroid cancer, but this patient even is high risk for papillary thyroid cancer, the recommendation to take total thyroidectomy and evaluate it. Malignancy, as is no questions, need to go to total surgical excision and will take it from there as papillary or medullary cancers. This is summarized with how can approach the thyroid nodule by history and evaluated, ultrasound, then according to the ultrasound, will calcify to the P9, very low, low suspicious, intermittent high. Then after that, if he's recommended for FNA, will do FNA. If P9, we need FNA, very low if have more than 2 centimeters, low should more than 1.5 centimeter, this up more than 1 centimeter. Then after FNA will depend the cytology of the system. If malignant needs surgeries, suspicious, or follicular neoplasm, follicular significant indeterminate, follicular suspicious neoplasm, or addeterminate follicular addeterminate malignancy. This is need to be lipectomy or go to the surgery. If P9, we need to surgery. If non-diagnostic, we repeated FNA after 6 to 12 weeks, and we'll take it after that if the increase in the by evaluated repeated ultrasound after 6 to 12 months of the nodule increased by 20% to repeated FNA. Now we'll finish that about thyroid nodules. I'm working if any questions.
Thank you, Doctor. Right now, I don't have any question. I would like to thank you, Dr. Ahmed, for giving us these 2 nice presentations. I think it is, you took us from the beginner level to expert level. And this is very nice from you. Thank you. And now we'll go to Dr. Afaf. Dr. Afaf, are you still with us?
Thanks, Dr. Ahmed.
Yes. Actually,
Okay.
I'm enjoying the presentation with Dr. Ahmed, Dr. Hussein. Thank you very much.
Thank you, Dr. Afaf. This is very nice from you. يعني دايما متعودين على تواضع حضرتك ومساعدتك لينا. Dr. Afaf, this is a sweet end for the first day. We will talk about pharmacological update of obesity management and obesity. Okay. I think we are all thinking about attending this presentation because every one of us is thinking that he's overweight and wanted to adjust his weight. So we will know from you how to adjust, right?
Hopefully, I can find the answer.
Okay. Let's start the last presentation, and inshallah it will be the best presentation as we always expect from Professor Afaf Al-Shammal. Thank you.
Thank you very much, Dr. Ahmed, with the very nice lectures that I really enjoyed from the previous speakers and your moderating the sessions. So the obesity as the pharmacotherapy for obesity. Everybody is asking about this, you mentioned, and it's really a chronic problems or it's a common problems that we are having. What is first we start with the introduction. The obesity is a potential life-threatening chronic disease. As the most prevalent metabolic disorder affecting human today, obesity requires multidisciplinary long-term treatment. As one of the questions they think is the obesity is a disease, is actually most of the guidelines, most of the whether North American or European or Far East Australian, most they are thinking about that obesity is really a disease in a way or another. So how can we classify the obesity? Is everybody the same? It's the only classifications that we have is the BMI. Is actually sometimes is not an accurate. Some they add the waist circumference, but the things that we are following till now and all the management is going with the BMI. So the BMI is the from 18.5 to 24.9 is considered to be normal. Anything 25 and above is like an overweight or obese. So 25 to 29.9 is than 30 and overweight. And the risk of the related diseases is starting to be high. 30 BMI to 34.9 is obesity class 1 and considered to be super high risk. The 35 to 40 is obesity class 2, super high. And the more than 40 obesity class, which is the morbid obesity with established disease itself. So anything is less than 30 as an overweight, and anything is above 30, it should be an obesity. The things, what are the major risks of obesity? Is any obese patient or person is healthy, is not having any problem? Is he at risk of any diseases? The things that we consider is like, and the risk is the obesity by itself. Obesity is increased adipokine synthesis, and this will increase the adipose tissue macrophages and other inflammatory cells, will lead to increase in the pro-inflammatory cytokines, and this will lead to impaired insulin signaling and insulin resistance, and this will affect the insulin, and the insulin will cause any impaired insulin will lead to type 2 diabetes. And type 2 diabetes, as we all know, will have the complications, microvascular or microvascular complications, which is heart failure, stroke, and CKDs. The other thing will affect the lipid production. This will cause hydrolysis of triglycerides, release of fatty acid, as I mentioned in the previous presentation, what will happen, and lipotoxicity. Lipotoxicity can affect the liver, which is NAFL, fatty liver, NASH, or cirrhosis, the long-term effect of NASH or NAFL is cirrhosis, and this will affect the body as heart or the quality of life. Things is when we have the lipid production as well, dyslipidemia, and the dyslipidemia is a risk of coronary heart disease, as what everybody knows about. So with the other thing is the mechanical stress can have intra-abdominal pressure. With increased intra-abdominal pressure can cause GERD, esophagus, or esophagus adenocarcinoma, understanding. The things is mechanical load increase on the joints will cause osteoarthritis. And the other thing, pharyngeal increase soft tissue, this might lead to obstructive sleep apnea. And the obesity can increase the activity of renin-angiotensin aldosterone system, and will subsequently will cause systemic pulmonary hypertension. So if we want to classify it, we can classify the multi-comorbidities with the obesity is metabolic, as the NAFL, gallstones, infertility, and cause cardiovascular, stroke, dyslipidemia, hypertension, pulmonary embolism, and coronary heart failure, type 2 diabetes, thrombosis, and gout, and could lead to cancers. And a lot of studies that associated between obesity and cancer, especially the GI cancer. The other is mechanical. Mechanical is like asthma, GERD, the incontinence, knee arthritis, sleep apnea, chronic back pain. And the third thing is the mental depression and anxiety. And being anxious, and they will be stressed because of the weight. So these are the category of the risk or comorbidities we have to evaluate with each of these patients or warn them with a complication can develop. Is the obese patient at risk of death, early death? Is actually this graph showing that when the gray color is normal BMI, so here is the proportion still alive or life expectancy with the age related to 70. Is normal BMI, you can see here, is almost 80% will reach to 70 years old. If the BMI increased 35 to 40, here with the light blue, around 60% will reach to 70 years old. If the BMI dark blue, 40 to 50, you can see here around 50% will reach to 70. So it does affect the life. What is the primary purpose of the medications used in obesity treatment? There is a statement being published in Circulation 2014 by Janssen. It said the rationale for use of medication is to help patients adhere to a lower calorie diet more constantly in order to achieve more sufficient weight loss and health improvement when combined with increased physical activity. So what model of management that we have to provide with the obese patients? Here is the BMI with the risk, and then we go with the treatment options. If the BMI around 25 with no risk is lifestyle modifications, and we're expecting with weight loss around 4 to 8% of the ratio. If the patient is having 27 or more, the BMI plus comorbidities or more than 30 kilogram, we have with the life modifications, we have to start pharmacotherapy. We're expecting to lose weight between 5 to 12% of the initial weight. Whatever the treatment that we're going to use, I'm going to cover it in the next few slides. If the BMI more than 30 kilogram with comorbidities or more than 40 without comorbidities is beside life modifications, maybe with pharmacotherapy, but we have to consider obesity surgery. But obesity surgery now with the new medications maybe will compete with, time will tell. So the obesity surgery, 14 to 33% of the initial weight, adjustable gastric banding, sleeve, or raw and dry gastric bypass. So these are, when you see the surgery, is the most effective reducing the weight up to 33%, and some of them up to 50%. The issue is with all the modalities of the treatment is to maintain the weight reduction rather than to lose it in a short period. And the other thing is discussion that happened with the management failure, including the surgery, when they regain the weight. So what are the drugs that have been used for? Is the drugs that will mechanism of action, whether it's central or through the GI. With these medications like lorcaserin, naltrexone, or phentermine topramide, those is central, working central to decrease satiety in the brain. With the orlistat is using through the gastrointestinal. The only thing is combining the central with GI is I give example for liraglutide, but it's the GLP-1 can be used for both. That's why sometimes the GLP-1 more effective than the others. What are the medications that we're having? We start with orlistat, Zenical. That was the weight loss expecting around 2.9%. Comparing to the others, but that was one of the medications that we released on the market, and the people were so happy and desperate to use it. But with time, still it is in the market. it actually is not effective compared to, it's not cost effective to buy a drug with costing around 150 riyal or 200 riyal to lose 2.9%. Okay, so but being approved by different societies. Propofol and Propropan is the 12.9%, but not approved by the major these societies. The naltrexone is being approved by EMA and the FDA, which is the reductions expecting to be 6.1 to 9.3, but it's opioid receptors antagonist. The propoin zonisamide is being approved by FDA 7.2 kilogram. And topramide is Topamax was not approved. And phentermine is being approved by EMA and the FDA with the expected to have weight loss 7.2 to 8.1%. Phentermine topramide, which is Kisma, is around 12.4% the reductions, and things is questioning the sorry. Okay. So the approval, but with the time that been like taken from the market. Supratamine is being approved by European, but is not approved by FDA. And the lurcaserine, I'm going to talk about it, been approved at the beginning, and it's around 5.8%, but there was a question of the complications or the risk that can have. I'm going to talk about it shortly. And then we have the regulatide, is like Victoza, Saxenda, around 5%. Everybody knows it's GLP-1, and been approved by most of the societies. And empagliflozin is GLP-2 inhibitor, but is not approved and is used as a base one. And we know as a reduction is around 2 kilograms, mostly with 2 to 4 kilograms, and so on. But what are the medication can be used for long term? As we have the Orlistat is been approved in 1999, and it's fat blocker. Orlistat LA is the 2007, and phentermine topramide is the 2013, and it's amphetamine derivatives, an anti-seizure drug combination. Naltrexone propropion is opioid antagonist, as I mentioned, antidepressant in 2014, and the liraglutide 2014 GLP-1, and then we get is the semaglutide, and lately is teriflunomide, which is released this year. So what is Orlistat? Was the first one being approved by FDA, and it's remained the largest or the longest licensed anti-obesity, as I mentioned, is still in the market. When one drug is being on the market, it means, well, it has to be like safe, so no major adverse effect, and the other thing is being effective. For sure, it's been safe, but effective, as I mentioned, is very small reductions on the weight. And with the competitors in the market, actually nobody is using it, and less being used because of the adverse effect. The side effect, as everybody knows, is the fatty oily stools, especially the top fatty meals, increased defecations, fecal urgency, and that was mainly the gastrointestinal side effects. The efficacy, Zendos, which is the Zenical in the prevention of diabetes in obese subject trial. So that was one of the largest controlled trial. The effect of Orlistat in 3,000 patients was found to be a total body loss is around 2.4 after 4 years. More important is lower the risk of type 2 diabetes, because I think is indirectly is by reducing the weight. Now we move to lorcaserin. Lorcaserin, when released on the market, or when we heard about it, when the studies is being published, everybody looking for this because that was released after Orlistat, which called Elbervic. This is a selective agonist of 5-hydroxytryptamine receptors, approved by FDA following twice daily 10 milligram lorcaserin in 2012. But the problem in 2020 February, the FDA requested withdrawal of this drug in the US because of the potential risk of the cancer, including pancreatic, colorectal, and lung. And the other thing is because of the risk of this outweigh of the benefits. So we don't want to give medications to lose weight while there is a risk of the cancer in a way or another. But the things in Europe that been taken from the market, potential breast cancer. So it's basically all the cancer that is, or most of the cancers that will be risk associated. So it's been taken from the market since 2020. Phentermine topramide is approved by FDA in 2012 as the first combination agent for long-term management of obesity. However, the EMA was not approved that in Europe for this medication because of what? Because of the afraid of abuse potential and the lack of long-term data and cardiovascular effect. And the other risk effect cognitive with the using of topramide, attention, language, and memory impairment. What's the mechanism of action? Because of the combo, this drug is mainly suppress appetite through the mechanism through the remain unclear. The central sympathomimetic action is the noradrenergic agonist is to enhance the release of norepinephrine, dopamine, and serotonin. The topramide, a gamma antipyretic acid, is approved for the treatment of epilepsy, and they found epileptic patients they lose weight. So with the significant weight loss, that was the making them to combine it with the other medications, and then for the weight loss. But is the things is with the adverse effect as with the insomnia, paresthesia, dizziness, dry mouth, that was making it less likely to be used, and needs to be titrated the medications to avoid because if they use it, okay, but if you want to stop it, it has to be gradually to reduce the risk of the seizures. Clinical efficacy showed the weight loss over 1 year for participants using the combination. With the group that compared to the placebo is 10% reduction of weight compared to the placebo 1.6. And they have another concord is the administered the same dose of phentermine topramide over 1 year achieved 9.8 reduction in the weight compared to the placebo 1.2. The sequel study, 2 years extension, it showed as well the reduction. So it maintenance over 2 years. So this is enforced the finding that the phentermine and topramide can result in meaningful weight loss and significant improvement of blood pressure, lipid, and fasting glucose and fasting insulin. The other one is naltrexone bupropion, that is contrary. It's a drug combination for long-term management weight loss and being approved in 2014 by FDA. The mechanism of action is an antidepressant bupropion, and it's used as a smoking cessation aid. It's a neurotic mechanism of action involved inhibition of dopamine norepinephrine reuptake. The dose escalation and advice effect. A slow dose escalations is recommended to minimize the side effect of nausea. Typical side effects include headache, dizziness, dry mouth, gastrointestinal discomfort. So the clinical efficacy is at a weight loss around 5 to 9%. Then we start with the GLP-1. That was a breakthrough when we have the liraglutide. As we know, the liraglutide has been approved by FDA in 2014. It's been approved as, before that, it's been approved, liraglutide is the 1.8 milligram for diabetes. And then diabetic patient, they notice that they're losing weight. So they continue the studies on the patient with the increasing, escalating the dose till reached to 3 milligram Saxenda, and that was the GLP-1. That was the injections daily to be approved for the obesity management, and needs to escalate the dose to avoid the gastrointestinal side effect, especially the nausea and vomiting. And the efficacy in the scale obesity and prediabetes 5 to 10%. So with the liraglutide, one of the things that is challenging is the price, because it's kind of expensive and is not available in most of the hospitals, and a lot of insurance restrictions. So the thing is, but overall, it's been safe and can be used without any problem. And making the people going with the same company, Novo, as have the other medications, is the semaglutide. The semaglutide is our lovely medications that really been used, abused, misused in the market. That was a long-acting GLP-1 that can be administered once a week, while liraglutide is short-acting when you compare with, because liraglutide you have to use it daily, and the semaglutide is weekly. So this is one of the advantages. And it's not only regulate blood sugar, similar to the GLP-1, but also play a role in reducing energy intake, increasing satiety, and reducing hunger. And some of the patients, they said, okay, if it's used for diabetes, how come it will not be at risk, or how can we make sure that I'm not at risk for diabetes? It's actually glucose dependent. So when the glucose is high, this will increase the GLP-1, reducing the blood sugar controlling. It's not only the semaglutide is being good for the weight, good for controlling blood sugar, and with the American Diabetes Association guidelines, it's been any patient with the high risk of cardiovascular, it should be considered in the management because reducing the MACE. In previous studies, an administration of 1 milligram once every week for 12 weeks resulted in weight loss of 5 kilograms. It will decrease appetite and food craving, better control diet, and reduce preference for the fatty or energy-rich food. But the thing is, should be known to everybody, that if at 12 weeks, 12 to 16 weeks, the patient is not losing weight, we don't recommend to continue with this. The semaglutide approved for diabetes 1 milligram, and Wegovy, the semaglutide here for obesity is called Wegovy, which is 2.4. So if not losing weight, you don't have to waste the money with this. Although it's the price here in Saudi is the cheaper compared to our neighbors. And maybe this is why we don't have it in the market, because everybody is using it. You can see a lot of people as I told you, is abused, making the restrictions from the insurance, making the restrictions, and would you believe it or not, with use semaglutide in National Guard, that is because of the abuse for everybody is using it, being restricted for diabetologists, because with diabetes patient, with the criteria to be used, the 1 milligram, we received in 2 weeks around 800 referral from primary healthcare asking for semaglutide. So this will make you think about the way being abused the medications. And then we go with the other thing, which is expecting to be soon in our market, is gastric inhibitory polypeptide, is GLP-1, and the GIP, which is tirzepatide. The tirzepatide is the GLP-1. It is secreted from L cells located in lower small intestine and colon. The GIP from the K cells located in the proximal small intestine, and the glucagon from the alpha cells of the megalytic cells of Langerhans. So it's a combo of two things that been used for the management of diabetes. The GLP-1 suppress the role of GLP-1 suppress appetite and reduce energy intake, while GIP has no effect on dietary behavior. So when GLP-1 and GIP are administered together, interestingly, since GIP enhance the satiety-inducing effect of GLP-1, the GLP receptors and GIP receptors agonist has the potential to be a new obesity treatment. Because with the use of medication, we need to escalate it to avoid GI. But the thing is, that we have, which is Surpass. They used the from the Lilly company that tirzepatide. They call Surpass. They use it, these medications with the compared with the insulin and the actins, compared with the GI, sorry, with the GLP-1, other GLP-1. So it's used with different medications, shown to be safe. The other thing is being effective in reducing weight, up to some of the doses up to 30%. So it means maybe with time, these medications will replace the surgery. So you can see the surgery is less than, if anyone working in a private can notice that asking for surgery is less than before comparing to the medication that you want to use it to lose weight. The good thing that is these medications to lose weight, but we go with the diabetes, with the obesity. Obesity is a chronic disease, and we know it's multifactorial. Multifactorials mean you have a genetics, you have environmental, you have different factors that you have to work. The other thing is a chronic disease. It means when we compare it to the diabetes, okay, diabetes is a chronic disease as well. Hypertension is a chronic disease. So if diabetes is controlled with medications, when the patient is reaching their target, would you stop the medication? Definitely not. The hypertension, if blood sugar is controlled, will you stop the medication? Don't. You don't stop it, right? But what about obesity? When they're reaching their target, they stop it. And then they go to square number one. And then we call for failure. Even for surgery. The surgery is step one to do, not the end of the things. That regain of weight in 4 to 5 years is around 40 to 50%. So this is considered to be failure if we have this result. Okay. So the things is whatever we're apparently is the injection, and it's weekly. Apparently, is tirzepatide is taking over in next few years. So it's in the United States around costing per month $3,000, and now it is in UNE is around 1,700 dirham per month, which is kind of very expensive drug. But when we have the expensive drug is like tirzepatide, making the liraglutide, which is Saxenda, considering decreasing the price, which was 1,200, now maybe they will decrease by 20 to 30%, so maybe around 800. And the other thing is being now is the obesity is being appreciated by the insurance, appreciated by the society. So the things is the can be covered in some plans, insurance plan. So so the things is the stop or to think about initiating the treatment, when to initiate with, and when you're going to terminate the treatment. You have to consider risk and benefit, and the treatment goal should be clear with the patient, because if anyone thinking about magic will not help him. The other thing is patient preference based on tolerability, adherence, and the cost of his paying from his pocket. So we discussed the things that what are so the patient he should be aware about all the cons and pros, and he should be committed. And the long term, as I mentioned, it has to be maintained for a long time or for the rest of their life. So in conclusion, most current guidelines recommend pharmacotherapy as the second line of treatment of this disorder following lifestyle modifications. Pharmacological treatment should be considered as part of a comprehensive strategy for the treatment patient BMI more than 30 or more than 27 and an obesity-related comorbidity. Third, the efficacy of medical treatment should be evaluated after the first 3 to 4 months of drug use. Number 4, data from most recent meta-analysis showed the overall placebo, the weight reduction with the use of anti-obesity drug for at least 12 months, range between 2.9 to 6.8. That was before the era of tirzepatide, which is going to be around 20 to 30%. Hopefully, it will be effective and will be handy. Thank you very much.
Thank you, Professor Afaf. We are very happy to hear from you this nice presentation. We have some questions. When we know the indications of Ozempic, okay, but when should we stop the Ozempic after achieving the required weight reduction?
Yeah, the thing is the Ozempic, you mean Wegovy. Ozempic is being used, the 1 milligram for the diabetes. Everybody, because Wegovy is not available, so everybody is using the Ozempic.
Hello?
The study, do you hear me?
The voice is interrupted.
Now, is it clear?
No. Yes, now, okay.
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 Okay. So the Ozempic is the one used with 1 milligram, which is the semaglutide 1 milligram Ozempic, called Ozempic. This is used for diabetes. It's not approved for obesity. Okay. The one approved for obesity, which is Wegovy, 2.4 milligram, which is mostly is not available. So the misconception of the population is the Ozempic is being used. But it's even if you want to use Wegovy, you have to start with the, escalating the doses gradually. So the studies showed if the first 12 to 16 weeks, if the patient is not losing weight, you don't have to continue. If
so
using
this
it
is
for
a
weight.
type of resistance?
Huh?
This is a type of resistance?
No, because it is not 100% the people is using it. Because the way it's been used, and some of the patients, they don't have suppression of appetite. They're eating whatever they have, or some they will reach plateau. They respond at the beginning, and this is plateau. This is GLP-1. So it could happen. Because if continue losing, it means this is better even than surgery, which is not the case. In a way or another, they will reach plateau. Some, they will reach plateau, but at least they reduce their weight.
Okay, some. Is there any role for genetic testing in obesity management?
Well, we don't do this because the genetics that we're using, unless there are association diseases, genetics, if it's positive, not mean anything because you will see the result of it. So the thing is it's not only genetics and environmental. You have the gene, you're carrying the gene, the same like diabetes. You're carrying the gene from your parents. But if you,
Dr. Afaf, I am sorry, the voice is up and down.
I'm the same.
With the microphone?
I'm the same position since I start.
Okay, now it is quite clear. Okay, can we have the answer again for the same question regarding the genetic testing? كده في حاجة.
ايه صوتها شغال
You hear me?
بيعلى ويوطى كده انت معلي عندك
اسمع اصواتكم بس maybe don't hear me.
دلوقتي بنسمع حضرتك بس هو few seconds وبيرجع يبقى له معلش نفس الكويستشن تاني genetic testing.
Yeah, genetic testing we don't do it because it's an cost effective. Do I have to do it to prevent something? You don't, because the genetics, if it's positive, you have other parts environmental. You hear me? Hello. You hear me?
I think we have a problem. حضرتك سامعاني كويس؟
سمعتك. Yes.
جميل.
Yes.
انا سامع حضرتك. طب يمكن المشكله في الكويستشن. طيب.
No. ما أنا مستغربة يعني نفس المكان أنا موجودة. So maybe.
ايوه هو السؤال ده يعني يمكن فيه مشكله.
Let me repeat. Genetics is not part of the screening for obesity because every time when we use something, it's cost effective. Is it cost effective to do the test because I know, because if it's positive, you will carry the risk, but the thing is environmental. So you have to have another thing. You have to work on, and then you will show the results soon.
And it will be the same management.
The same management.
Okay.
Not change.
So testing
now,
for genetics will not change the management, so there is no cost
so
benefit.
the cost effectiveness is not considered because of cost effectiveness, you don't consider it. Yes.
Okay. We know that metformin is weight neutral, but I noticed that in some patients it causes very good weight reduction. How do you think about this?
What is it? Metformin?
Metformin, yes.
Yeah, metformin, it's not neutral. Metformin, it showed the studies is reducing the weight 2 to 4 kilograms, but is not approved as a weight management drug.
Okay, very good. How to overcome side effects of Saxenda?
Okay, this is the to overcome the adverse effect, which is nausea and vomiting, by escalating the drug. And the spacing, because some of the patients, they will start like Saxenda 0.6 milligram and then increase the dose at a 1.2 and then 1.8, 2.4 to 3 milligram. Some of the patients, I depend on their symptoms according their symptoms of the nausea and decreased appetite. Some, they will have loss of appetite on 1.2. So I ask them to maintain on 1.2 till they lose this benefits, and then they escalate it. So maybe you delayed the escalation of it. The other thing, which is most important, with all GLP-1, because what causing the GLP-1 weight loss? It's not only central. As I mentioned, GLP-1 is gastrointestinal. So the work on the stomach motility, so delayed gastric empty. So when we eat, the absorptions will be or digestion within 2 hours. This will delay the gastric empty. So what I advise patients to be taken on empty stomach to avoid the nausea and delay the doses. I mean, escalate gradually.
Okay. Any documented side effect of semaglutide on the retina?
No, they are not like liraglutide. I understand this question. Liraglutide, if we want to use it for diabetic patients, we have to make sure the retina not to have retinal hemorrhage, okay, to avoid this. Semaglutide, not proven yet. But when you talk to the patient, because there is no adverse effect, but as long as the same group, we have to take precautions if the patient's having an active retinal hemorrhage. Otherwise, but doesn't mean it's not contraindicated.
Okay. What about using oral semaglutide for weight loss in non-diabetic patients?
Yeah, repulses, the semaglutide orally is the same because it's glucose dependent. But what I noticed by using it with the patient, because we have to use it gradually, we have to use it daily, we have to use it as the first thing in the morning with empty stomach, little sips of water or half cup of the water, and then they have to wait for half an hour before they eat. But what I found with the patients, diabetics, because it's been approved for diabetics, I'm using it for diabetics only. The things is more adverse effect. We feel it is like every day. And just observational, that is not as effective in weight as the others.
As injectable, same semaglutide, right? Yes. This is what have been observed by all the patients, not only the doctors.
Yes.
In case of failure of semaglutide injection in weight reduction, what would be the next step?
Well, because we go and to assess what are the problems, because this is drug failure. We don't have a lot of options. This is the problem because we are hand tied. So no other with medications, if there is a risk for the patient, they are diabetic and the BMI is high, we have to refer for surgery.
Surgery. So if I will keep sending you the questions, we will not close today. It was a very nice presentation and everyone is interested in it, even the non-medical. Okay, so thank you, Dr. Afaf, for this very nice choice of a very good presentation. And we wish to see you with us next year, inshallah. And maybe we can meet in another meeting like before.
Inshallah, inshallah. الله يحفظك. شكرا. Thank you very much.
شكرا تعبنا حضرتك معنا.
الله يحفظك. أهلين.
مع السلامة. So thanks for everyone who attended today. This is the end. We should have ended 11 minutes ago. Thanks for more than 900 persons who attended today. And tomorrow, inshallah, we will start at 4 o'clock. Again, the same question is being answered. Full registration is the only one candidate for taking the credit hours. Okay, full registration means to present his document, his registration number for the Saudi Commission, and to pay the simple fees provided by us. Okay, other doctors or medical personnel who want to attend for their own interest, we are open the floor for free. You can attend for free, just for improving your knowledge. And thanks for all. See you tomorrow at 4 o'clock. Thank you.